John Berkeley is, I can't wait.
I'm not quite ready yet.
So, no further ado, Dr. Cusick, it's all yours.
Thank you, Dr. Woods, for the lovely introduction. And thank you all for coming. So today I'm going to talk about a clinical condition that has been resolved in, I would say, majority of cases by a neurosurgical technique that relies on very simple anatomical principles. Now, in anatomy, we can talk about systems in anatomy, like the vascular system, the nervous system, etc. Or you can talk about what relationships are. So what is next to it? So the rectus abdominis is next to the external oblique. So y'all know what I'm talking about here. And I hope that I'm talking to a lot of your students here. I enjoy being with you in the lab, so thank you for sharing that with me. So the case that I'm going to be talking about, an older term for this was tic douloureux, which means literally a wincing, that's a tic, a sorrowful wincing, because many of the patients who have this condition would experience a shooting pain that would cause their face to contract on one side. So that's tic douloureux, but the modern term for this is trigeminal neuralgia. Neuralgia is a neuropathic pain that's generated in the nerve and not by the stimulus, which is non-painful. Okay, so this is a case where a non-painful stimulus gives a painful reaction in the nervous system. Is that clear? Okay, so the great save. This term was introduced by Dr. Furlick, who expresses this as a really wonderful experience for a neurosurgeon to be able to, in many instances, give a complete recovery for a patient from an excruciating situation. So that's the great saying. Okay. Before diving into that, I wanted to give a little plug for WAM. So the WAMI medical students are in Bozeman, and they're studying their foundations material. We have 30 first-year students and 30 second-year students for a total of 60 students, Montana residents. They finish with an MD degree, so it's not a pre-doctoral program, it's not pre-med, and they get their degree from the University of Washington School of Medicine, and it says Montana on that. Most of the time can be spent in Montana, doing clerkships as well as a foundation. So if you want more information about this, talk to me later, or Dr. Wood has contact information for me, or that you can talk to the director as well. There's a goodly number of students are accepted from our local colleges and universities. So it's something to think about. Okay, back to the subject. Okay, so I wanted to present an overview of the trigeminal nerve problem, and then start kind of working through the anatomy of the problem. So ending up starting with the nerve, the blood vessel, how the blood vessel relates to the nerve, causing the problem, and then approaches to treatment and a resolution from there. Okay, so the surgical treatment is called a microvascular decompression. And it was developed, or the problem of the vessel next to the nerve was identified already in the 1930s. And this surgical technique was developed in the 1950s and 1960s. But I think it was in the 1970s and later that it was recognized how effective it could be. Okay. I have talked about the older name of trigeminal neuralgia. So this is a disorder of the trigeminal nerve function. Trigeminal nerve is a cranial nerve. So they tell me how many cranial nerves there are. There are 12. Okay. Can anybody tell me what number the trigeminal nerve is? 5. Awesome. Okay, so the trigeminal is born in 3. Okay, so it's the 5th cranial nerve. It is the largest cranial nerve. Has this massive sensory input from the face, and it has 3 divisions. That's why it's called trigeminal. The first one is the ophthalmic. Ophthalmic relates to the eye. The second is the maxillary, which is like the area of the cheek. And the third is the mandibular, which is the area of the jaw. And each one of these divisions is going to exit the skull through a separate hole in the skull. Okay. So the main function of this nerve is going to be sensory. So here you see the distribution here of the ophthalmic, the maxillary, and the mandibular nerve. So those are the sensory distributions to skin. And then the mandibular nerve here is also going to be innervating what we call muscles of mastication, the chewing muscles, okay, like the temporalis muscle. You've heard of these, temporalis masseter, the pterygoid muscles. Okay, so they're innervated by the mandibular nerve. And so a typical kind of representation of this, this color-coded person shows that each of the divisions is kind of a wedge-shaped area and has a part that goes up onto the scalp like that. They also are going to go to deep tissues. So it's not just skin, but like the ophthalmic division also goes to the eye, to eyeball, the sensor from the eyeball. And the V2, the maxillary, is going to go to the nose, the sinuses, and the mandibular, the mouth, and the teeth. So you can test for these different divisions clinically with a cotton swab and say, can you feel this? Close your eyes. Can you feel this? And then, test the other side. You can test the strength of the jaw muscles. And so those are kind of clinical approaches to examining the nerve. Okay, so let's talk about the problem. Okay, the trigeminal neuralgia. It's a facial pain in one or more of those divisions. Typically, it's in the mandibular division. And it's this most commonly up to 55% in mandibular, very severe in intensity. So this shooting, lancinating pain will last a couple of seconds to a couple of minutes. One of the devastating aspects of this pain is severity, but also an inability to predict when this is going to happen. So just common stimuli can cause the pain. Like like brushing your teeth, or a guy shaving, or puff of air against your cheek, chewing, talking, anything that would give a low threshold. You understand what I mean by low threshold stimulus? Okay, something, a light stimulus will produce this severe pain. Piercing, electric shocks, a good description of this. So this is a central pain syndrome. It's not a pain syndrome that's caused by the nerve that the nerve endings. It's happening perhaps between divisions of the nerve closer to the central nervous system. More common after 50, it's almost never found in children, more women than men. Okay. Michael, can I ask you to say a few words about your experience of your, does this match anything that you had 20 years ago?
Yes.
So,
I wouldn't
This is
say
a-
anything, I'd say I wouldn't
What's that?
recommend it. I would recommend not going through it.
not going through this, this is Michael Michael Reagan, who's from the local newspaper, and he told me this before, and that he had suspected that he had trigeminal neuralgia, and that this kind of corresponds to his experience. So people with this condition have a major impact on their quality of life and on their mental health. And so you can imagine what it would be like to never know when this was going to happen. The triggers, I went through some of these. The triggers would be cold, chewing, brushing your teeth, blowing your nose, talking to the neighbor. It can be mistaken for other conditions like sinus problems or an infected tooth. I read of a woman who had a sinus operation and teeth pulled because they weren't able to make this diagnosis. So this is the innocuous stimuli that causes are suggesting that something is happening with the nerve further in. Okay, so we've kind of laid out what the problem is. We'll go into a little more detail about the anatomy of trigeminal neuralgia. Now, the trigeminal nerve comes from an area of the brainstem called the pons, and then it's going to have its three divisions leave the skull. Okay. Here, the mandibular nerve, you can see it's going up. It's foramen. Foramen is a hole in the skull to reach the mandible. And this is one of my favorite nerves here. This is the maxillary nerve. I know Dr. Wood likes this one as well, because it has this long straight course from its foramen all the way out to the infraorbital foramen on the cheek. It also supplies some extra sinus and the upper teeth. So you can imagine that the puff of air on the side of the nose or upper lip could, or anything activating this area with innocuous stimuli could cause that pain. Because it's not just the skin of the cheek, it's also deeper structures as well. Okay. Now, I'm just gonna run through this. So this is how we think this might work. That is by a vascular compression injury, 75 to 80%. And that what's happening is due to this compression, there's a demyelination of the low threshold fibers. The low threshold fibers are the ones that are giving you that cutaneous input, like light touch on your skin. Okay, and they're myelinated and they conduct quickly to the central nervous system. The pain fibers are more lightly myelinated and they conduct more slowly. So there are these two specific pathways going to the central nervous system. So the thought is that there's demyelination of the light touch system, and that those fibers are next to the pain system. So when light touch is activated, so is the pain system. And it's a direct contact to contact system called ephaptic spread of the transmission. And this is thought to be the way compression of the nerve can give rise to neuropathic pain. So now you understand what I mean by neuropathic. So it actually happens not at the skin in the periphery, but actually where the nerve is going into the central nervous system. Okay? So directed electrical crosstalk between the fibers related to light touch and to pain. So this explains how benign stimuli can produce pain. But not all benign stimuli, and it won't happen every time. And that pattern of timing is a big part of the problem. Okay, so let's talk about the trigeminal nerve as it comes off the brain, as it comes out of the skull, because where it is anatomically is going to make a big difference in how this syndrome comes to be. Okay, so here is a picture, a photograph of the brainstem, the human here, and this is the pons. So the three divisions to the brainstem: the midbrain, the pons, and the medulla. And this is the trigeminal nerve, which is the largest of the cranial nerves, right there, coming on kind of mid-pons. So we're going to see how. Okay, so actually we're going from the brainstem out to where the nerve divides into its three parts. Okay, so here's a picture showing the brainstem where it's going out to those three parts. Okay, so here is an MRI. Have you seen an MRI speak for it? Do you know what type of MRI this is? Is it T1 or T2? It's T2. And this is T1. Okay, so you can see what the arrows are pointing to. That's the trigeminal nerve. Okay, so you see that the trigeminal nerve is attached to this is the pons here. When you look at MRIs, this is the back of the head. Okay, and then that's anterior. Looking at there's the eyeballs there, and then so you can see here this is the pons, and here's the trigeminal nerve going toward the space that it lives in the skull, okay, which is called Meckel's Cave. So it's headed toward Meckel's Cave. And by Meckel's Cave is where the problem is going to happen. Okay, so here's another MRI. Okay, that one was axial. So it was in this plane. So you can see the pons and the cerebellum behind. But this is a coronal MRI. And again, this is you don't need to know what type. So here's the three divisions of the trigeminal nerve as they're going toward their trigeminal cave in the floor of what's in the middle cranial fossa. Okay. Now this is a really interesting dissection that I found in an old anatomy lab manual. And what it shows is this is your Meckel's Cave here. And you can see that there are three divisions of the trigeminal nerve going out through their respective holes. So, and I think that's the main point that I want to show here. Here's the trigeminal nerve going into its, this is called the trigeminal ganglion in the trigeminal cave. The other thing that you can see here is that this is really complicated. There's a lot going on. Okay, well, hopefully Dr. Wood won't make you yes.
I think I'm oriented properly, but I'm not entirely sure. Can you kind of describe what that picture is?
Okay, great. So here is the eye is right here, and this is actually the bony top of the orbit has been opened up. So you're looking at the top of the eye right here. This is the midbrain back here, part of the brainstem. Here's the optic nerve and chiasm there. Here's the internal carotid artery coming in to supply blood supply to two-thirds of the brain. And then cranial nerves that are going to be moving the extraocular muscles are coming through the superior orbital fissure like that. B1 is following them. B2 and B3 have their own openings. Is that?
Yes, thank you.
Okay. Thank you for the question. I'm sure that more than one person was wondering. There is an artery here. See this artery here? It's called the superior cerebellar artery. And this is the culprit. So stay tuned. It doesn't look all that threatening. Okay. So I'm going to skip this one. This one is even more complex. So when we look at the trigeminal nerve, then we're looking at the foramina that the different divisions are going to. You can't see the one B1 goes through the superior orbital fissure, and then B2, the feminine rotunda, you can't see, and then this is for the valley, which is the opening for the mandibular. So standing room only. This is the mnemonic. Okay, superior orbital fissure, room is foramen rotundum, only is foramen ovale. Have you heard that before? No. No, you- okay. As the nerves go to to the openings in the skull, they're actually covered with this thick sheet called dura and it's kind of like plastic. It's pretty rigid. And you can see here this is called the middle cranioplacid here. And the trigeminal nerve is going to go to that trigeminal cave by shooting underneath the dura there, and then it's going to be lying in a position like that. Okay, so here is, and that's a really good idea, looking at your skull. So our three divisions go out 3 holes. V1 through the superior orbital fissure, V2 through the foramen rotundum, and that's colored in green, and then V3 foramen ovale. And then again, when you look at this side, the dura's been dissected off, so you can see V1, 2, 3 there. And then here the dura is placed, so you can see it's completely inside of our trigeminal cave. Okay, so here's my skull. This side of the wall.
Why is it more common for women than men?
I don't know the answer to that. Sometimes those are just observations that we don't have a clear answer for. Okay, so the purple is going out the superior orbital fissure. That's V1. The pink going out foramen rotundum, V2. And the orange is going out foramen ovale. And so the purple comes out the orbit. The pink comes out into the pterygopalatine fossa. Can you see that? Okay, and then foramen ovale, it drops right down into where the muscles of mastication are found. You see that? So they're really going in different directions. If you want to see how these are going with the skull afterwards, I can show you. I just wanted you to see where the branches are headed. Okay, so let's talk about the cranial vasculature. You have 2 vessels, the vertebral artery and the internal carotid artery that supply the brain. Internal carotid artery is about 2/3, and the vertebral artery about 1/3 of the blood supply to the brain. And so here's a diagram. I saw some of the students were looking for the foramen that goes in the transverse processes, and there's the vertebral artery that goes through this foramina that it causes a little canal to form. And I saw that some of you were looking at that. So that's going to be part of what's applied to the posterior fossa. Really. Here we have, I'm trying to speak English, I'm sorry. I forgot I said posterior fossa. Here's the internal carotid artery that goes through the carotid canal. And then if you look at the base of the brain, sort of, this is probably not too clear. The trigeminal nerve is right there. And here's a blood vessel that's running really close to it right there. This is a diagram of the blood supply to the brain. And you can see this area here is the circle of Willis. Have you heard of the circle of Willis? Okay, we'll get there. Is that tomorrow? So the circle of Willis is here. It's a connection between the intraoperative artery here and what we call the vertebrovascular system. So the two vertebral arteries come together and they form the basilar artery. And then it's going to give us two largest arteries. This one is called the superior cerebellar. It comes to the top of the cerebellum. And then this is the posterior cerebral, which goes to the occipital lobe of the cerebral cortex. So here's a diagram that doesn't show this as a flat plane, but shows, it's a 2D picture, but it kind of shows what's overlapped and what you can't see well by looking at actual specimen. So here's our vertebral arteries coming together. Here's our basilar artery, and there's our superior cerebellar. It's going to go to the top side of the cerebellum, and there's our posterior cerebellar in the center. There's a bunch of other arteries that are named. I'm an anatomist. It's hard for me to stop here. So basilar artery branches are going to go to the inferior side of the cerebellum, medulla, pons, and to the superior side of the cerebellum, and to the occipital lobe here. So this is about a third of the tissue of the brain. Here is an angiogram that you can see. Is it dark enough in here to see this? Okay.
See the colors?
So this is an LVERT, a left vertebral artery injection. And you can see here it's joining the right vertebral artery. This is the basilar artery. It's formed by those two coming together. This is the division of the basilar into the two posterior cerebrals. I don't know of any place else where something like this happens, where you have two vessels making one or dividing into two. And then you have the superior cerebellar artery coming out here. I think that's actually labeled. So this is our superior cerebellar artery, the culprit. Okay. Now, the point here is that there is this vessel that can have loops, or it can be duplicated, that's right next to the trigeminal nerve. So here's the trigeminal nerve right here, the sternum, and here's the superior cerebellar artery right there. It's got two divisions there. And so you can see how one of those could cause compression, and then we could have that demyelination, effective conduction, and the trigeminal neuralgia. Looking at the superior cerebellar artery, this is a latex injection. I know you have latex injections in your specimens you're working on in the lab. But you can see this is the extent of that superior cerebellar artery. And there are a couple other pictures here that show variations. And this is important. So here's the place where the artery contacts the trigeminal nerve. Here's the caudal branch contacting the trigeminal nerve. So this is just straight anatomy. This is a latex injection looking at brainstem. trying to convince you that what you're doing is relevant and of interest. Okay, so here you have a double SCA. Then you've got here's a double, right? Here's a double. So there are a lot of variations that can occur. And this artery doesn't care where the trigeminal nerve is. It's going to this double, right? And variations in blood supply are not usual. Okay, so I was curious to see whether I could show the trigeminal nerve next to the SCA some plasminated brain in the lab back in Bozeman. And so now that we've looked at this together in the drawings, you can see this is a vertebral artery in there. You see that? And here's the basal artery. Here's the superior cerebellar. It isn't usually launched off of the brainstem like that. But can you see a little bit?
Mhm.
Okay, and here's the trigeminal nerve. So you see those are pretty close. Okay, so this is a different brain. I don't know if you can see this, but there's the trigeminal nerve and there's the SCA. They're crossing each other really closely. This side doesn't look quite as close. There's the trigeminal nerve and the SCA is over here. So, simple anatomical problem. Therapeutic approaches, mostly anti-epileptics. First-line treatment like carbazepine. Surgical interventions, there are several different ones besides the microvascular decompression. There's injections of glycerol. And those are for cases that are refractory to medication. So the microvascular decompression that I'm going to show is 80 to 90% effective and only 20% recurrence after 5 years, which is pretty remarkable for any type of brain surgery of this sort. So I wanted to show you the anatomy one more time. I'm sure we'll get my mouse to that. I thought this was really lovely. Basal artery. It doesn't show. What?
I thought we duplicated the screen.
Well, let's try again. It's an old one. it working?
Yep.
Okay, so I wanted to show you this basilar artery here. And this one here is the SCA, superior cerebellar artery. And there's the trigeminal nerve. This dissection was done by a neurosurgeon. And he's actually flipped the trigeminal nerve upwards so that it's going backwards instead of forwards. So here's the ophthalmic, the maxillary, and the mandibular division. You can see little pontine arteries. So this is, I think, a pretty nice demonstration. Okay, back to we talked about approaches to treatment, the decompression surgery, and the patient story. That's where we have this. Okay, it's considered one of the worst pains that a human being can experience, trigeminal neuralgia. The relief through successful operative intervention is recognized as one of the most satisfying operations in neurosurgery. Okay, so hopefully this will work. And this is a it's not showing. We practiced this before.
You can take the laptop screen and put it under the.
Oh, there you go. Yeah.
There we go.
Hey.
Oh.
Nope.
No?
False alarm.
No.
You see it now?
Yes. Okay. It's not on. Okay. It would be nice if we could make that full screen. But
Yep. Shall we start?
sound?
Hello, ladies and gentlemen. My name is Aaron Cohen. Thank you for joining us for the first series of videos related to microvascular decompression surgery for medical refractory trigeminal neuralgia. Preoperative MRI in this patient demonstrates potentially a vascular loop against the left-sided trigeminal nerve.
See that? This is Tom's here. Blood vessel.
You can see that the high-resolution MRI allows a very detailed assessment of the anatomy in the region. This patient subsequently underwent a left-sided retromastoid craniotomy. Let's go ahead and review the relevant anatomy. Again, a left-sided retromastoid craniotomy was completed. This is the tentorium at the edge of the arrow. This is the petrous bone, obviously the fifth cranial nerve, and the vascular loop that is along the shoulder of the nerve. This is a typical classic neurovascular conflict in trigeminal neuralgia. Again, the most common form of vascular conflict or vascular compression on the nerve is along the medial shoulder of the nerve, as demonstrated here. You can see the motor root of the trigeminal nerve and again the main sensory root of the nerve. We'll go ahead and start dissecting the nerve from the motor root. You can see that there could be additional branches hiding just anterior to the first one. These arachnoid members can be very thick, requiring meticulous microdissection to allow the vascular loop to be mobilized. Here you can see a true vascular loop that was pressing on the nerve at this location, causing some discoloration of the nerve. This finding is very reassuring that the offending vessel has been found and addressed. It's important that the superior petrosal vein that can sometimes be here could hide some of the vessels, and really meticulous examination and inspection in this area is important to avoid missing those vascular loops that could be potentially just anterior to the nerve at the upper
How
portion
is that normal?
of the shoulder.
That's, see, this is normal. That's it.
I do not generally use fixed retractors. As you can see, dynamic retraction is used using the dissector in my left hand, in my left or right hand. And the superior petrosal vein is frequently not taken, as it is unnecessary to do so using dynamic retraction techniques. Here is further mobilization artery to make sure it is completely moved away from the root entry zone of the trigeminal nerve. I use a shredded Teflon and place the Teflon just proximal on the nerve and push it distally to be able to mobilize the artery completely. Use of the shredded Teflon in pieces allows a more efficient modeling of the implant to fit the area of the neurovascular conflict and prevents delayed dislodgement of the implant. You can see the superior cerebellar artery branches under some spasm at this region. We'll go ahead and use a pattern soaked gel foam to relieve the spasm. Further inspection around the nerve reveals no other compressive lesions. Here is the papaver soaked gel foam. You can see that it's really important to look around the nerve completely, 360 degrees. Even though one compressive vessel has been found, you still have to look around the inferior and anterior aspect of the nerve to assure that the compression is adequately addressed. Here is another piece of Teflon that was placed. Again, you can see these pieces of shredded Teflon are placed in a stepwise fashion and are pushed forward. This allows the entire cisternal segment of the nerve, as well as the root entry zone, to be decompressed. And this maneuver is important for optimizing postoperative pain freedom outcomes. Here you can see more panoramic view at the root entry zone, making sure there is no vessel along the root entry zone at the level of the brainstem. Here you can see that I was unable to find any further vessel to immobilize. You can see that adequate amount of Teflon that was used to decompress the artery. I prevent using too much Teflon, as Teflon granuloma could potentially be a source of recurrent pain. Here you can see complete inspection around the nerve, especially superiorly, making sure that the loop is not contacting the brainstem at the level of the nerve.
Pretty steady payments. Pretty sure I'm not capable of doing that. And one of the aspects that you got from this is that you don't really know what you have, even with a high resolution MRI, until you're in there. You don't know if you have a true loop or whether you have more than one loop. You don't know exactly what's being compressed, if there's another vein you need to take. So knowing your anatomy and knowing variations in anatomy is very important. So I'm glad that you're giving them a really good grounding in anatomy here. Okay, so the next one is the patient experience and safety use. Okay, I can't make it.
Okay. I can do that.
Okay. So this is just a little video of a young woman who had had this.
We've always enjoyed cooking together, but it wasn't fun when you can't enjoy what you're cooking because you're, you know.
I think this was the most excruciating pain I've ever had in my whole life. I mean, it was zapping, lightning pain on the right side of my face, my jaw, my mouth, everything.
It was heartbreaking for her. It was heartbreaking for me to watch it and see her be a different person, it wasn't the real show. So the opportunity to visit Hopkins was exciting. As exciting as brain surgery can be. It offered hope.
So trigeminal neuralgia is facial pain that affects one half of the face that's classically described as sharp, stabbing, electrical pain. The cause of trigeminal neuralgia is often by something that causes irritation or inflammation of the trigeminal nerve. The trigeminal nerve is the nerve that controls all the sensation to one half of the face. The pain tends to be episodic, meaning it comes and goes.
Before Scott discovered Hopkins, I was having breakthrough pain at work while I was on medication, and I literally couldn't speak, like to my bosses, to my coworkers.
We know that for some individuals, medications are ineffective and or cause too many side effects.
Medication wasn't working for me. It might work for some people, but it wasn't working for me.
There are many treatment options for trigeminal neuralgia. The one that tends to be the longest lasting is called a microvascular decompression. Microvascular decompression is a surgery that we use to separate a blood vessel that's compressing the trigeminal nerve. In order to do this surgery, we make a small incision behind the ear, with a small opening in the skull, identify the trigeminal nerve, and under the microscope, slip small cushions made of Teflon to decompress the blood vessel of the nerve. The microvascular decompression surgery takes approximately 2 to 3 hours to complete. And with this procedure, the vast majority of individuals get long-lasting pain relief. For 20 years or more, individuals can be free of their trigeminal pain.
Since the surgery, I've been able to resume my normal life. I went back to work 6 weeks later. I've been able to play sports. I've been able to cook with my husband, ride a bike, things that I would never do before. I still can't believe that I had brain surgery. I can't believe I went through it. I can't believe it was me. I don't know where I would be if I hadn't had the surgery. I think they saved my life.
So that's the patient impact. I think it's important to realize that that's really what we're doing with studying anatomy. Is getting applications that are life-changing. I have a few slides on the body harness program, but before I do that, I want to ask if you have any questions. Yes.
You talked about variations. How common and major can those be? I had an AT block recently that caused some ptosis, and my neurologist said that shouldn't happen. I could be wrong, but it sounded like just there was something a little different about my anatomy compared to other people's.
So where was the block placed?
Auricular temporal, so right around here.
Um,
And I'm not sure if that detail, essentially my question is how, obviously there are these minor variations that need to be corrected. How common are more major variations, or what's kind of the range of a common variation, if that makes any sense?
Well, that would be a major, I'm just kind of sifting through.
Yeah.
Knowledge of the neural connections there. The auriculotemporal nerve is going to be traveling with the branches, temporal branches. Our facial nerve innervates the ocular ocular, which is going to be responsible for closing the eye. So ptosis is not an expected result. Ptosis would be expected from damage to the ocular motor nerve, which comes from the brain and goes to the motor palparis superioris. You probably looked this up.
Yeah. Yeah, my neurologist found one other case of someone having this, but kind of what I don't know is how big a variation that is and how common that sort of
would be,
variation is.
a very good variation.
Okay.
It's very unexpected, and I'll have to think about that for a while. And I'll let you know if I can remember something. Okay, any other questions? Yes.
Yeah, the nerve that basically is getting sparked over to, you showed a slide where there was basically a loss of myelination of the main trigeminal nerve, but adjacent to it was a pain receptor nerve that's really what's giving, that's basically allowing conduction between those two membranes, and it is basically what this Teflon wrapping is doing is just sort of taking the pressure off so that those two nerves aren't butting up against each other so hard, so that they aren't making that contact, and that it creates a little bit of space. And does anybody try to, I don't know if anybody can really put in some kind of,
Way of measuring the pressure.
well, no, I'm thinking about how could you replace that myelination? Is there any way that you could put in, oligodendrocytes, but something that myelinates the nerve and repairs the insulation that's missing between those two nerves?
I think you will get some degree of repair in this situation.
They have tried that.
I would need to look up references, but I would be surprised if there isn't some recovery of function due to recovery of myelination.
Yeah, so because of your reducing the pressure.
Of a typical situation with nerve regeneration. Now, this is analogous to a peripheral nerve, and it's going to be distal to the ganglion, so it would be analogous to spinal nerve distal to the dorsal root ganglion. So we're looking at something near regeneration of the myelinating nerve cells might well occur.
Yeah. And when you show the three different possible treatments, one of them was it just a kind of a medicinal kind of thing? It wasn't non-surgical. You had a slide there. The first one was kind of a complicated name, but I can't remember. But it was that just a medicinal
it's
type of?
an anti-epileptic drug, and there are various anti-epileptics that are used in treatment of this. And it's only when those fail that they look for surgery.
When you're at the dentist, is this where that injection back at the rear of your jaw is going? Is it hitting one of those branches to deaden the nerves in your lower in your
They
mandible?
used to inject with alcohol to in an attempt to. When I was in graduate school, they talked about alcohol injections in order to destroy the trigeminal ganglion. That is not a modern approach. They do glycerol injections, which sounds not very sophisticated either. So let me run through a couple of slides and see if you have questions about the body donation program. Is that showing? Okay, so I am director. We have Ian Bozeman. We have bodies that are donated. They're about 24 per year. 10 of them are used in WWAMI, and those are for a year. And then we have the other ones are loaned to schools around Montana for a period of 1 to 5 years typically, so that the schools have pro sections to show the students. So it's more on a long-term basis. This program has been in existence since 1975. We have, all of these are donations. They have a signed form called a declaration of consent, or next of kin can also make the donation. We have, we really appreciate this donation very much. The families have given up the final resting place, the final disposition of a loved one while the study is being made. So this is greatly appreciated by the students and the faculty. Donors are from Montana, within 250-mile radius of Bozeman. Impact of the program in Montana is to medical students, nursing students, the A&P students in Bozeman. They're circulating with thousands of students through their A&P labs, where they have 4 cadavers that are being studied as pro sections. We can provide more information. We try to help the families by providing with burial in Sunset Hills Cemetery or cremation that we provide for the families. So my question that I always present to the students is, what's the best way to do this? How do we show our respect and our appreciation for the generosity? As an anatomist, my view is to do the job well, to do it right, and to study the information so that you and your future, in many cases, patients, will benefit to the greatest from this. We have a convocation of things where students get together and express their gratitude, some music, some reading, some poetry, and they write letters to families. So that's all I have to say about the donation. If you have any questions on that, I'd be happy to answer them. Yes?
I just had a question about the earlier portion of your talk about trigeminal neuralgia.
Yeah.
Interesting talk, by the way. Thanks for coming. You had mentioned earlier in the talk that the disease usually presents over age 50, but then in the particular cases that you looked at in the surgery, it was due to a vascular loop, which seems like an anatomical feature like that would be present from birth. And so I'm curious, I would think that you would have a presentation of trigeminal neuralgia in pediatric cases, but that's not the case. So I'm wondering, is the development of these vascular loops like sort of a degenerative condition, or why does it present at an older age?
Maybe it has to do with changes in the vessels, with injury to the intima of the vessels causing a stiffness in the vessels so that it doesn't move away from that. With the pulsing of the collapse, so this would be like similar to, but not exactly like atherosclerosis. And that might explain why it happens slowly. But this is pure conjecture.
Makes sense.
Or could it be a varicosity, like a varicose vein, where you're losing
Should be, yeah,
some
Yeah.
tone in that?
Yeah.
That it just sort of expands too much over.
sure.
Rather
There isn't
than
a
an
reason.
atherosclerotic situation.
Well, thank you, everybody, for coming.
Yep, and, okay, we out. Come
Good
look
luck
at these
with your,
plastinated brains. These are real brains.
Yeah.
They're plastinated, special procedure that hopefully one day our students can learn at 110.
yeah, I was taught how to do this at Montana.
Thank you.